I'm so happy and so grateful to be able to introduce our today's guest, a great mind and a great human being, Jaakko Seikkula, Dr. Jaakko Seikkula, a clinical psychologist, family therapist, and a professor of psychotherapy at the University of Ivascula. Is this the right way to pronounce it?
Yes,
Ivascula?
sounds very. I recognize the word. Yes, please.
Thank you.
Duvascula.
But
It's the,
you're also a world famous creator or co-creator of the open dialogue approach, which is the most effective and a very well studied approach to treat psychosis and schizophrenia. So, welcome and thank you for accepting the invitation to this podcast.
Thank you for the invitation.
I would like to start with an email that I received from a 21-year-old girl who writes to me that her life has just ended. She's crushed. She has just left the doctor's office. And after 10-minute conversation, she heard the diagnosis, or as she puts it, it's a sentence, life sentence, because the doctor told her she has schizophrenia. It's an incurable genetic disease. There is nothing she can do about it. She has to take medication for the rest of her life. I
Mhm.
understand this is one of the possible ways of understanding psychosis and schizophrenia, but I know that there are other ways to talk about it, to treat it, to see it, to understand it. So, my first question is, what would you say to this girl?
Well, I'm very sad for her, and I'm very irritated for the doctor who says something like that, without any scientific evidence of the statement that he or she is giving. And the sad part is that I know that the doctors so many times say like this without any knowledge about what they are talking about. And they don't need to take any responsibility of their words, even if they really put a burden for the lady who met with the doctor. And I would say to her that this is not true. The doctor is not speaking how the things are, even if you may have the diagnosis of schizophrenia. There are many ways to search for help, and of course, it's very much based on your own activity, how much you are ready to start to work with the issues on your life to make it more understandable. How come this reaction arised, and how is it connected with your life and everything. So that's what I would say, and of course I would very much like to look for a team who would take care of her and her family.
You have been working as a clinical psychologist. Clinical psychologist means that you receive patients, you see patients, and you treat them, you help them. So you have been doing this for over 40 years now.
Mhm.
So you have
That's
a lot of
okay.
experience to answer a
Yes,
question like that.
yes. I yeah.
And
45 years, perhaps that was my first working place that was a part of my studies in psychology. And all the way through, I've been interested mostly of the most severe mental health problems as psychosis. Actually, already my thesis, my of master thesis, were about the question: what are the factors for children to have later on in their life mental health problems? So this really has been my destiny, my professional destiny.
I remember reading that you started to become interested in this in the early 80s in Finland and
Yeah.
in Lapland, which is, I believe, a very difficult place to live. And you had very high rate people with schizophrenia. Why do you think that was that in Lapland? Is it because you have little daylight? Is it because the days are short? Or is it something else that
Mhm.
made it more prone for people
Yeah.
to develop schizophrenia?
It is true that this part of Finland, the very northern part, Lapland, and also as the very eastern part of the Finland, there is an incidence of mental health problems like schizophrenia much higher than ever. Actually, we made a research and found out that in the middle of 80s there was 33 new schizophrenia patients per 100,000 inhabitants. I have never seen in any place that high incidence of schizophrenia, if we use that word. And also there are many other illnesses. Someone said that this part of the Finnish Lapland and also in Sweden is like an illness pocket with many kind of illnesses. And there has been some research about it, and some people say that it may be related that it's a very rural area. The villages are very isolated. They live very isolated life and so on, so that they are not so much input or earlier there were not so much input from outside that would fresh their communities. It may be related with some of those kind of issues.
So you started in the early 80s in Lapland, in Finland, and you took a different approach because open dialogue, which was developed from an open meeting, it was open meeting in the beginning, and then it turned into the open dialogue method. It's a very humanistic, it's a very loving way of treating people with psychosis and schizophrenia with very minimum use of medication. Can you tell us how you developed this method, how you came up with this idea, which was against and still is against the mainstream psychiatry and mainstream ways of understanding and treating people with mental crisis?
Well, I suppose that one of the decisive steps was that when I went to work in this very small psychiatric hospital called Kerobudas Hospital in Tornio in Finland at 80s, we were a team with two doctors, one psychologist, some nurses, social workers, we all had an interest to develop family-centered care, as we named it. In Finland, we are very fortunate because there is a long tradition conducted by Professor Yrjö Alanen with his approach that was named as need-adapted approach. And Yrjö Alanen with his team developed the idea that every response should be adapted to the unique needs of every family in a severe crisis. And they were very keen to integrate individual psychotherapy. They were psychoanalysts, so it was individual psychodynamic psychotherapy with family therapy. And when we started to work, we followed the very traditional way of working that when one is hospitalized, doctors make an anamnestic interview, psychologists, myself, make a clinical testing to define the diagnosis, and then we came together and made a plan for the treatment. And we realized that this is not working. Only very few of the families could participate in this traditional way of working. But then 1984 we heard about this what they had done with Professor Yrjö Alanen in Turku in Finland about this open meeting. And that was really a kind of big experience, that there is a possibility to change the way of meeting with the very first meetings when someone is hospitalized into the hospital. And we started to organize this open meeting by reorganizing the idea work. We stopped meeting with the professionals without the clients being hospitalized. And we also stopped to think that families need psychotherapy to be changed because there need to be some indications, some problems in family. I started to follow the idea that always invite the family. It's an enough big crisis if someone is hospitalized in psychiatric hospital. And this change that happened in August 84 really was the decisive step to come into the way to start to meet openly. We were very successful, very fortunate in the beginning because the very first meetings were very successful. But also what happens was that we started to have a very surprising experiences that we did not understand all. What is this? What happens? Because there were no textbooks, there were no ideas how to include really family into the part of the system of care in psychiatric hospitals. And that's why we started to think that we need education, new education, and we need to follow what happens, so that from the very beginning when organizing the open meeting, we also started to look closer what this is all about the processes, about the outcomes, and also started to have education for the staff. Perhaps I would like
we want
to
use.
yeah, please.
Please, go ahead.
No, only to say that in the beginning we really thought about this open. We did not speak about dialogues. It was a new way of organizing the planning of treatment when someone was hospitalized in the very beginning.
So if we were to use a metaphor, if you have a plant in a garden and this plant is beginning to show us signs of sickness, you cannot take the plant out of the garden, heal it, and put it back into the same garden. Because obviously, if a plant is sick, it must be connected with the environment, with the whole garden. So the idea of not isolating a person with an emotional crisis from the environment, from their friends, place of work, from the family, is fundamental, is one of the most important things. Would you agree?
Yes, it's the most important thing in life, because I really think that human mind is relational. There is no human mind in isolation. There is actually no mind inside of us. Everything is in the relations, in the relationships, in the social relationships, within the families, with the social networks, and also, of course, in the relationships that we have in our bodies. So that you cannot see human life as isolated. You cannot think that we only need to cure this symptom and then it's done, because this symptom or this behavior that someone may have immediately affect all the others around, and of course all the others around may have affected in some way, that someone got panic or someone has very big anxiety. And this is really the case, that everyone is needed to be involved, invited, and taken care of, and they can get help for themselves, and they can start to help each other.
This is the way of seeing a mental crisis as a bigger problem, not trying just to deal with the symptoms, but trying to get to the source and solve the whole problem, which is so important, because isolation is one of the most severe punishments for prisoners when they're put into a single cell and stay there for weeks. People are not made to be isolated. So taking a person in an emotional crisis and isolating them from their own environment, from their family and friends, from the home where they feel safe, would this be helpful, or on the contrary?
It makes more problem. Of course, there is one point, for instance, isolating yourself in a hospital when you may have, for instance, hearing voices or having some hallucinations. It may increase safety. It may give you a feeling that now I'm safe with all the threats of life that I feel when I'm out there. But at the same time, it creates problem, because, as you said, the most dangerous issues in having a crisis is isolation from the human relationships, and also in the way that I've seen so many times that people, when they have like, as we call, psychotic problems, they think that they need more distance from other people and they isolate themselves, and this is a very dangerous and non-constructive strategy of survival, and that's why we need to introduce the other options to to take care of the relationship, to encourage the relationships, even if it may feel difficult in the very beginning.
So the open dialogue method is, on one hand, seeing a mental health crisis as a bigger picture, including the environment where the person has been living, but also including one of the oldest healing methods that we have known as humans, which is dialogue. And there was a Russian philosopher, Mikhail Bakhtin, and in 1929 he introduced the idea of dialogueism, which is the power of conversation, which is what we have been doing for centuries to solve problems. So I know you've been interested in Mikhail Bakhtin's work as well. Did he inspire you?
Yes, yeah. Actually, in my mind, Mikhail Bakhtin introduced a new way of understanding of human life. I spoke earlier about the idea that human mind is relational, and in my mind, Mikhail Bakhtin is the one who really opened the door to understand this part when he said that human life is participating in dialogue. To live means to participate in dialogue, and in his way he adds that the dialogue is not a mean or it's not a tool for receiving something, but dialogue is the thing, because in dialogue we found what we really think. By being in dialogue while speaking with you, I can learn what do I think. And it's not the case that I would have inside of me a lot of thoughts or ideas, and then I give those thoughts and ideas to you. But those thoughts and ideas, they are made in our conversation, and this is what Mikhail Bakhtin is saying. We met with Mikhail Bakhtin as a kind of solution to the confusing experiences that we had with some processes of care in early 80s in our system, and the confusion came out that many times, repeatedly, it happened that when we tried to do everything to make change in our clients, to follow the plans that we have made, and they did not do that, but they chose their own way. And in the end, the change started when we changed. For instance, we could give up. We have no longer any ideas because you did not follow the plans, the good plans that we thought that best for you. And let's see what happened. And this was the time when the change happened. And this was a very, very, very dramatic, a bit catastrophic conclusion, because everything is focused on that they need to be changed. I mean, our clients, our patients, the families need to be changed. And then all of a sudden you are in a situation in which you start to look at yourself. You need to change. And if you change, this opens the doors for all who are in this participating system. The family is the one who is hospitalized or in crisis all over. And in this kind of experiences, I really started to make a search. What is this all about? I read a lot of philosopher. I understood that this has a lot to do with language. I was very keen to read a lot of text of philosopher who had been working on language, and I did not find the response. But then in one day, in one conversation that we had, one reminded that do you remember that when we were students in the university, actually I studied in the University of Jyväskylä at 70s, and there was a professor in Russian language, his name was Erkki Peuranen, who was speaking about this Mikhail Bakhtin. And the one who listened to my description of the confusion that we had, she said that actually that reminds of the ideas that Erkki Peuranen had found in Mikhail Bakhtin's text. And then I took a paper in which there was an article about Mikhail Bakhtin's ideas of Dostoevsky's novels. And I read that, at the very same minutes as the one has said it, and I was in shock because what I read there about Mikhail Bakhtin saying it was a literature research. He described how Dostoevsky's write his novels. He was actually describing our experiences in the open meeting. What in a very simple way, what we're told was that Mikhail Bakhtin said that Dostoevsky's novels there is no one hero and other complementary characters, but everyone has their own truth that no one else can deny. And the only option for these characters is to be in continuous dialogue with each other. He defines this a kind of polyphonic novel. There is as many stories as there are people who speak on the pages on the novels. And then Bakhtin adds that it makes a very problematic situation for the author, because the author can no longer have a control of the characters because they are so much in dialogue, and the author needs to be in dialogue with the characters. And this was exactly what we were dealing about. That when people come into the meeting, they have so much to say, and no one can deny the truth of the other. This concerns also the professionals. We in psychiatry, we cannot deny the opinion of the social work because they have their own way and own obligations to look at the problems. And the only way is to be in dialogue, and there is no longer any author who can define that this is what we need to choose, but we need to find ways to be in dialogue to create a new way of doing, respecting all the voices that are there. And this was my opening meeting with Mikhail Bakhtin in trying to find the ways to dialogue. And step by step, while understanding more, we adopted the idea of dialogue from Bakhtin's works.
That's amazing. So for somebody who has never heard of open dialogue and how it works, if there is a person, because we are used to the medical, biological, the mainstream way of thinking about schizophrenia or psychosis or people in mental crisis. And we're a little bit afraid because these people behave strange, they say strange things, they see things that we cannot see. So we usually are afraid of them, so we isolate them. So they go into a hospital, they're given medication, or they go to see a psychiatrist. But the open dialogue approach is different. And in so many ways, one of the ways is that if somebody is in serious mental crisis, you say we should not wait until they become quiet, until they take their medication, until they're gone through the phase of the very dynamic emotions. But within 24 hours, we should sit with them during a meeting, and the meeting should include family members or colleagues from work, social workers, psychotherapists, at least two from trained in the open dialogue method. And we do not force any topics, but we sit together and we say, so what would you like to talk about? Where would you like this conversation to go? Meaning everybody is equal during that meeting, including the person in the mental or, yes, in the emotional crisis, which may actually be the first time that they are allowed to speak about their emotions and they feel noticed, they feel important, and they feel heard.
Yes, yeah. And it's so important is that we meet with people as early as possible in their when they are in their emotional turmoil, the big need and no responses at all, what this is all about, the big confusion, because this kind of emotions, they open the doors to start to deal with issues that are not there in your everyday life. People may start to speak about something that happens that never has been spoken about earlier in their family. People may start to speak about their inner experiences that they never spoke before, and so on. And the one of the biggest mistakes in psychiatry is exactly what you said, to put people in the hospital and start to weigh the effect of medication before we start to invite the family and start to speak about the issues. Because then we lose this energy that is related with the confusion, with the emotions that people have. And when we come to the open meetings with these big emotions, people become more coherent in relation to those closest to them in their life, the most important people in their life. In a way, everything is constructed into the relationships in which they live, instead of thinking that they are in isolated process for themselves, between themselves and therapist, themselves and doctor. But now everything is there in the relationships. And it's true that the system seems to be scared for psychotic problems. And that's why there is so big need to control, to have the medication and say to the people that this is your illness, this is not true, and do so much against the idea that people really could have access to mobilize their own resources for surviving.
So there was an American psychiatrist, Dr. Bertram Caron, who worked with psychotherapy with people with schizophrenia. He wrote an article about Mr. X, who was supposed to be an incurable schizophrenic, and many psychiatrists gave up on him. And he was healed with psychotherapy by Dr. Bertram Caron. And he said that schizophrenia is a state of fear, of a state of constant fear, where there is so much fear inside of you that has never been let out, never been released, never been understood, talked about, that finally there is so much pressure of this fear, you're like a volcano, you just erupt. And this is psychosis. So there is a different possibility of understanding psychosis and schizophrenia. And in open dialogue, how do you understand, how do you explain to us, to ourselves, to people in emotional crisis, what would be your understanding of psychosis or schizophrenia?
First of all, I don't think that something like psychosis as a category exists. Neither schizophrenia, there are some words that we use, and the pity part of those words is that they orientate us to search for the pathology, psychopathology of the people who may have psychotic reactions or feelings about their reality. And in my mind, as we have been thinking in open dialogue, it's a response. Hearing voices is a response in a huge emotional stress, or as a terror of dying, as Bertram Caron also used the idea. And it's a response that we need to survive. It's a survival strategy in an extreme stress. In some texts, Bertram Caron said that if you have 6 different stress factors in your life, you are in a dead end, and in that end your mind develops a kind of imaginary world that is needed to survive. So it's a kind of tool of our embodied mind to survive the extreme situation, and it's not a psychopathology, it's not a pathological state. Actually, it's an illustration of the working mind, because the mind really has ways to deal even with that extreme situation. And if we take this stance, we have a curiosity about the experiences. And it's so important because when we are in a meeting And if someone starts to speak something that I may think that perhaps it includes some psychotic experience, it may be the most important point to deal with the issues that did not yet have any other words. The core of the terror that he may have. And for me, it means that I stop everything and ask, wait a minute, what did you say? Did you say that you have a control of the thoughts of your neighbor? One young man once said that. Can you help me understand a bit more about it? And definitely, I do not say that this is a part of your illness. This is not true. But having a curiosity to help people to start to speak about the issues, and there's nothing to be afraid, because usually with those kind of questions, people also may give. Perhaps they may give confusing explanations, but they also start to have more and more constructive ways of dealing with what has happened in their life to the things that they are dealing with their hallucinations.
I don't remember if it was Dr. Bertram Caron or whether it was Dr. Frida from Reichmann, who also used psychotherapy to treat schizophrenia. And they said that it is a coping mechanism and it's replaying some repressed emotions. And they use the example of someone saying that they can see a person with blood flowing out of their eyes. And it was clearly a hallucination, a vision, because the psychiatrist said it's impossible because blood does not come from people's eyes. But actually, when they started to talk to this person, and when the fear subsided, and when this patient felt safe and important and heard, he actually remembered then that when they were a child, they saw a neighbor being crushed by a car. And then blood started to flow out of the eyes of that neighbor when he was crushed by the car. So they said that anything, someone hallucinating, seeing visions, and saying things which seem impossible, it's all coming from some repressed memories. They were so difficult to digest that they were just hidden very deep in the subconsciousness. Is this also your experience?
Yeah, I suppose that this example is one of my texts that I have written. It was even a bit more dramatic stories, because the man who was speaking about this, actually in the meeting with his mother, the mother started to describe that this happened when he was 8 years of age, and he was with his father on the yard, and the father was making service for the truck that he was driving, and all of a sudden a part of the truck fell down, and father was there, and he exploded into pieces, and this young boy, 8 years of age, was the only one who saw this, and really the blood were exploding off the eyes, and this story was all the time with him when he was living in a very chronified way of his life. So it may be that the experiences that people have are so terrible that we cannot imagine that something like this really can happen, and that's of course the idea why we need the curiosity. The non-ended curiosity, open curiosity all the time, to encourage to speak more, because it may be that there are some issues, as you say, repressed from the memory, or that are so heavy that the memory cannot deal with those, and it's restored in the memory of the body. And in psychosis, many ways, the body is speaking, and we need to listen to the body. We need to listen to the embodied part of the stories.
So, in open dialogue, as you said, we need to approach another human being with curiosity, without judgment, without fear that he's different, that they're behaving in a way that we usually do not behave. Do not reject them, but on the contrary, accept them, sit with them, and talk to them, and just ask questions and listen. So, one of the most revolutionary things about open dialogue is being equal to the person in a mental crisis and approaching with empathy and with the will to understand rather than judgment and wanting to put a diagnosis on someone.
And the idea with the question is a bit specific one because I don't do interview. I don't have in my mind ideas or topics that I need to clarify because the one that we call interview is created in the conversation, and the idea is to follow every utterance that the one who is speaking. And it may be in concrete that I many times repeat word by word something that one said. You said that you became very sad when your father moved apart, one lady said. Could you say some more about it? Could you help me understand a bit more about it? And this is what we call interview in the dialogical practice. We do not have any specific ideas that we need to make circular question, we need to make solution-oriented question, we need to do this and this kind of question to have a proper information for our mind. But now we entirely follow the stories of the one who is speaking by repeating some part of what he or she spoke and then encouraging to speak more, with an idea that people create the stories of their life by themselves. In a way, they become authors of their lives more than they were before.
When you repeat somebody's words, it becomes less emotional because words which are spoken aloud work in a prefrontal cortex rather than the limbic system, meaning you can hear and understand and start being more rational about it. Like the person you are interviewing, the client, as you don't call them patients, you call them clients, which establishes also a different connection because you don't put yourself higher, but you invite this person in a mental crisis as a friend and you create a community with them, which is the most humane thing you can do to anyone.
Yes.
So if we had with this girl that wrote to me and she was in a very drastic mental state, could you describe a meeting that we could have with her? What would it look like? Who would be included? Who would start the conversation? And who would end the conversation? And in what way? And how many meetings would we have with her? Just one or more?
Well, of course, we do not know anything about why did he went to the doctor and what was the so-called problem or challenge in her life to search for help. But meeting with her, inviting her family or someone else that she would like to have there, and then having as for instance 2 of us in open dialogue, we are very much motivated to have more than one present because many times the stories are having so many voices that it's impossible to think that one person can hear of them, and if we are two, we can listen a bit different parts of the stories that people are telling, and this is the way to go. We made an open question: how would you like to use the time that we are now here? And then, well, I don't have anything special in your mind. I could repeat, well, you don't have anything special in your mind. How should we go on to really encourage to say something? I need to search for help. You didn't need to search for help. and you were in need for help, and what happened, and so on and so on. So it's very pragmatic conversation, very concrete, and I'm not so keen to hear let's say the comprehensive description about the problems. I'm much more keen to hear the sub sentences. You said this, and stop very much, so that this is the way to go, to have the words. People say the most important issues in one word or in one sub sentences, and we really need to be very open to be present at the moment when something most important is said. And in the end of the meeting, we will talk about the issues of what the professionals need to speak about. If we think, if there is a doctor who started to think that perhaps there is needs for some type of medication for sleeping or having not so much anxiety, and we think of other options of help that is needed, and so on. We really, in a crisis, we never know how much is needed. I've done a lot of research about it, and psychotic crisis may be dissolved in one meeting, but at the same time you may need to be ready for an active work of 3 years, so that you never know in the beginning what is the way to go. But as a part of open dialogue, we need to guarantee the psychological continuity in the way that we are available all the way through. That is needed. Also in the way that, of course, it may be that professionals change their job and so on, but if there is the same team, there can be new members into the team and the continuity is guaranteed.
So this person that comes to you in mental crisis meets with the same people as many times as needed, as they want to, and they do not meet in hospital, but they meet at home where they can feel safe and when the environment is more friendly.
Yeah, mainly this is the proposal in the beginning. Of course, not all want to meet at home. They prefer to go to clinics, and that's okay, to meet in a place that people want to meet. But especially in the beginning, we were always proposed, but we would like to come to your home and do this, but also accepting the other place. And if someone is hospitalized, for instance, in the suicidal threat or something like that, the same team could be part of the meetings during the hospitalization, again to guarantee the continuity, that there is no breaks of the process if there is some more serious period of time.
I never thought about it this way, but it just occurred to me now that it sounds like a very Buddhist approach. You're very patient, you're very accepting, you take it the way it is. You're not trying to change someone, you just sit with this person as they are, and you listen to them and you let them be what they are.
Yes, exactly. It may be also
Does it have anything to do with Buddhism? No.
Consciously not, and of course, but this is a reference that has said many times. Yes, yes.
So there are 8 principles of open dialogue. Can we go through the 8 principles, and can you explain what each of them mean?
The background of this that you call as principle was that in the middle of 90s we had a research project with Professor Jukka Aaltonen, who was a consult of the system for a long time. And the interest was to find out how is this new system of care working, in which we really had this mobile crisis intervention teams going homes. And we did this research by analyzing what was written in the patient records. And we made a kind of content analysis, qualitative content analysis of the descriptions, and found out that if there is an optimal process of care in this new system in which people were no longer hospitalized because of psychotic problems, there seems to happen the things that, first of all, there was this immediate help guaranteed. That the first meeting was organized during the first day after the contact, so there were no waiting time before come to the meeting. And the second part was that there was also a perspective to the family and social network, and we defined this as social network perspective in the way that in the very beginning, the family members and some other parts of the social network were invited to the meeting to be together and follow as long time as needed. And the third point was that there was a flexibility in a way that the optimal care guaranteed the use of different methods based on the needs of the clients. The next step is to guarantee the responsibility of the team. That the team was available in the very first contact and also throughout the process, and guaranteeing the psychological continuity in the way that we go across the boundaries of the service system. In the team, they may be invited social worker if the family is in need for support of the social care, and going across the boundaries between hospital and community care. And then in the end, to make enough safety to tolerate the uncertainty, because we do not have any ready-made responses or solutions, and that's why we need to focus on dialogue, generating in dialogue to understand what has happened in the life, to understand us, but of course to understand for the people who are in the crisis. Very shortly said, these are the basic elements of open dialogues.
7, actually, not 8, like I said, sorry. So tolerating uncertainty is very unique, because I think it's very difficult for many people to grasp the idea that you are supposed to help someone and heal someone, but you are ready to tolerate not knowing what to do, what is the answer, and wait for the answer and the solution to appear within the circle of people during dialogue. Is this correct?
Yes, exactly. Yes. And the idea is that in this way we can give more space for their own resources to be mobilized, to look for options and ways to go on in their life, instead of thinking that we have solutions or we have the idea or we have the guidelines. And this change of mind, change of thought is very, 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 very different. It's a very big one. To really think that make a space safe enough for the people to grow up in their own way they want to do it and to go on. And of course it's a challenge in every meeting, because we are healers. We all the time think that you should do this. This is what you should do. And my ideas are not helpful. They are my ideas that appeared when I'm listening to my own voices, my professional voices, perhaps personal voices also. And that's why we really need to learn to be in a dialogue in a way in which we also can have a bit control of our urgent needs of be helpful with our advices, but being helpful in the way to open up the dialogue. This is why we need the training. That is a very basic part of developing the open dialogue.
The most amazing thing about this part is that you don't take away the responsibility for yourself from your client, but on the contrary, you encourage them to be fully responsible and be a part of the process of getting better, which in traditional medicine, the doctor knows you're just the patient, so you follow the rules. You're not even supposed to question what the doctor is saying to you. But here in this approach, when you empower people, you give them more tools to cope with their own lives and their own emotions.
Yes. Thinking about the lady that you spoke gave an example in the very beginning. This is the difference. What would be the response in open dialogue? Would be asked, how did you explain to yourself this what had happened in your life, and not to give our explanation. You have this because you have schizophrenia and you will need medication the rest of life, but really very consistently follow the ways of thinking about the situation that people are having themselves. And of course, in the beginning, people do not have explanations, and that's the idea. But that's why we need, for instance, repeating the word and step by step start to find more connections to what has happened in life.
That's just amazing. You mentioned therapists. They have to be prepared, they have to be educated, and there are several requirements they have to meet, or several things that they need to learn. So they have to be curious, so they have to be open minded when they approach a person in an emotional crisis. They have to be flexible, they have to be open, kind, willing to learn, willing to listen without judgment, and they have to try to understand a human being rather than make a diagnosis. It's a definition of a perfect nurse, perfect doctor, perfect psychologist, perfect psychiatrist, or should I say, a perfect human being. How many people do you have? How many therapists do you have that meet all the criteria?
Well, I hope that we have many of them. Actually, what has happened during the last years in the world, that there is a growing up of the interest of open dialogue. And what we have started to do, we have started to organize training, educational programs in different countries. And now there are some 35 countries in the world in which there are some projects of open dialogues. And in these training programs, what we in a way try to learn is a way of working that you describe. Perhaps to point one thing, what has shown up to be very important is to be known with my own personal voices. How are my own relationships from which I come, and this is part of the program, and to do that in a dialogical way, so that I learn to be in dialogue with my relationship with my life. And because in dialogue we all are humans, psychologists cannot speak with anyone. Jaakko can speak, or Beata can speak, or whoever, and how to combine. And at the same time, I know that I have professional duties. If I meet with the people who are in a risk of suicide, I need to know how to be in the situation, not to increase their probability of death, but to do the opposite, and so on. So the combination of the professionals and the personal voices is the one to learn, perhaps most important.
You have educational programs that train people who have all the qualities which is mentioned.
Yes.
So I could come and have a training and become an open dialogue therapist.
Yes.
Great.
Yes. Yeah.
I think I'm going to do it. Okay. So we talked about the method, the origins of the method. We talked about how it's being done. And I know that it's one of the best studied methods in the world because you were experimenting and you're also a scientist, so you were writing science papers. So what's there's so many differences between the open dialogue and the traditional way of thinking about people in mental crisis. And what's the rate of your clients being healed and having normal life?
some years ago, we published a paper in which there were long-term follow-up, 20 years after the crisis. We took all the registered data that we have in Finland and made a comparison about those people who were living in the small province of Western Lapland comparison to the rest of Finland, and the differences were really big one. Those who got open dialogue care in the very beginning of the crisis 20 years ago, they were 30% of them were living on a disability. Some 25% were still in some contact with the system, and perhaps 1/3 had some medication, neuroleptic medication, and very little had been in hospital. And then, in comparison to the treatment as usual, half of the people who were in traditional system were still in treatment 20 years after. 80% were on medication. They all had been more than 1 month in hospital, and more than 60% were living on a disability. So in every those ideas, the results are doubled in or the poor outcomes, which is a very concerning, because in traditional psychiatry the outcomes in psychotic crisis has become worse during the evidence-based medicine area since the very early years of 90s. But in open dialogue, we really have seen that most part of people can return to the full employment, giving responsibility, and so on. This is very encouraging, even if it could be better. For instance, in the way if all could have followed all the time in their life in open dialogue, I suppose that the statistics have been even better than they are now.
So the rate of people in open dialogue who go back to their normal life is 80%, 85%?
Yeah, in 2 years, if we had a controlled research 2 years time, and the best outcome was 9 of 10 could return to full employment. Yeah, almost everyone. And of course, we all understand that this is totally different what we are learned to think in psychiatric problems, as the lady that you said had heard from the doctor who in my mind made a criminal point by this statement that he or she gave to the one.
So there is one more thing that we didn't talk about, and I think it's worth mentioning: the use of medication. In open dialogue, you do use medication sometimes, as little as possible, and it's not the first thing that you go to. Is this correct?
Yes, it's especially thinking of this permanent medication, for instance, starting the psychosis medication, neuroleptic medication. Do not start that in the beginning, but if you need some, for instance, coming down in anxiety, you can have tranquilizers, and you need sleeping pills and so on, and you definitely can use those medication, but only use the psychosis medication if this active psychosocial intervention is not helpful enough after some weeks of the care. In our research, it came out that in the beginning, some 15% used them. In 2 years' time, some 25% used them. Mm-hmm. Yes, mm-hmm. Yes, and so on. So it's very minimal.
So the 80% or the 9 people of 10 healed with open dialogue, it's not thanks to medication, and they do not take medication for the rest of their lives.
No.
But on the contrary, they live a normal life without medication. Is this correct?
Yeah, it's correct. I don't have statistics how many of them use medication, but main part did not use medication. Of those he recovered totally, and some of them use. But the idea is also to, when you start the medication, immediately you start to think how to stop the medication, so that there is a kind of a program to going down of the process by the process that is going on. But you really need help. It may be that you need to have meetings every day in the very beginning of the crisis for 1-2 weeks before you have intervals in the meetings. So it's not at all to say that you do not need the medication, please go home, but have a very, very active involvement in the life. And then you can replace the medication and avoid the harmful effect of medication.
So if this girl that wrote to me, she watches our conversation online and she would like to come to the open dialogue treatment, where can she go?
I know that there are teams in Poland, for instance, who are adopting this system. And of course, I don't know which country where he's living, but we really have already options. And actually, I have emails almost every day from all around the world, people asking for help. And now we can also make connections to some therapists to start to meet with them and try to find out services without the traditional way of dealing.
So, because when you are in Finland, you do the open dialogue only in the Finnish language, or do you do it also in English for people who come from abroad?
It's Finnish language, yes. And people living, many people ask, would I need to move to Finland? And it's not a good idea. Welcome to Finland, of course, but to move to Finland to have the treatment, it's much better to start to search options in your own context.
So, where can we learn more about you and about your work and about open dialogue? Is there a website that you would recommend that we can go to?
There are many websites on open dialogues. For instance, one British website in Open Dialogue UK or something that also give information of the ongoing and planned trainings that are going, and also have some information about it. But if you Google Open Dialogue, you really can find quite many options of different sources and different parts of the world, and also in different languages. As I said, that already in 35 countries in languages. Our books that I have been writing has been translated in 16 languages and so on.
And also a lot of scientific papers that you have written about yes, the open dialogue, but also about understanding human psyche. Yeah. I have so much admiration for your work. Thank you so much, because you make so many people feel better and have a better life. So thank you for that.
Thank you for your kind words, and thank you for inviting to this interview.
Thank you very much, Jaakko. Thank you, and all the best.
All the best.
You. I hope we will see and meet in Finland.
Yes, hope the same.
Thank you. Bye-bye.
Bye-bye.